All right, so I think I'll just get started, and we can wrap up early when it's complete. So let me mute. Oh no, let me turn that off. Okay, so welcome everyone, and this is a talk on perioperative glycemic control. Can everyone hear me? Okay,
Yes.
excellent. Okay, so my name is Ryan Kroll. I'm one of the internists at Scarborough Health Network. Been here for a couple of years now. Um, and as far as this case goes, I have no relevant conflicts of interest that I can think of that would pertain to what we're going to discuss today, unfortunately. No, I'm just kidding. So, in terms of an outline, we're going to first discuss a case that I encountered a couple of years ago when I was during my training. We can discuss whether or not we did the right thing. We'll talk a little bit about the glucose targets in the perioperative setting. We'll do a review of some of the literature, and then we'll finish up with some takeaway points. Okay, so we'll start with a case. This was a 77-year-old male that was seen in the perioperative clinic. He was scheduled to have an elective right bone-anchored hearing aid replacement and left-sided tympanoplasty and oxyculoplasty. It was going to be a day surgery done under general anesthetic. He'd been having episodes of otitis externa regularly over the preceding decade, and his hearing had been deteriorating, and the decision was made by the ear, nose, and throat specialist to proceed with this procedure. He did have a long-standing history of diabetes, and when we asked him about his blood sugars, he did have a glucometer, but really didn't check regularly and was kind of vague in his answers. Sometimes he'd say, well, maybe they're in the 20s. I don't really check it. I'm not sure. But really didn't give us any good answers. But every time he would attempt to maybe give an answer, he would say something like it was in the 20s, maybe this one time, or maybe in the high teens. I don't really know. His past medical history was notable for coronary artery disease with a drug-eluting stent to the LAD many years prior, a moderately severe COPD, moderate severity COPD with an FEV1 of 66%, type 2 diabetes. His A1C was, I believe, 8.5%. And it had been in that range roughly for many years when we looked back at Connecting Ontario. His BMI was 36. He had dyslipidemia, hypertension, GERD, previous cholecystectomy, remote, and sleep apnea, but wasn't using a CPAP machine because of difficulties wearing the mask. In terms of his medications, he was on hydrochlorothiazide, atorvastatin, budesonide formoterol, 2 puffs in the morning, umeclidinium, 1 puff in the morning, salbutamol as needed, sitagliptin, gliclazide, and venlafaxine. So when we look at sort of his cluster of medical conditions, we can see he's already on triple therapy for COPD, was on 2 oral agents for diabetes. Of note, despite his history, he was not on an ACE inhibitor or aspirin. He had been told previously to stop taking aspirin, but he could not tell us why. He denied any history of previous bleeding and couldn't explain why he wasn't on it, but just noted that even despite having a previous stent and coronary disease, was not continued on antiplatelet. So on physical examination, his blood pressure was in the 130s over 70s, but otherwise vital signs were normal. There was no sign of obstructive cardiac disease or decompensated heart failure. And aside from his BMI of 36, the physical examination didn't show a whole lot. His A1C was, as we mentioned, about 8.5%. A little bit of protein in the urine, but nothing crazy, and a mild leukocytosis, but again, it really wasn't anything to write home about. Now, granted, this was when I was a trainee, so the final decision was after reviewing with the attending, but we did say, even for this day procedure under general anesthetic, that he was not fit for the surgery, as we thought we needed to control his diabetes a little bit better. Or to at least get a better sense of what his control was, given that this was an elective procedure. So we gave him sheets to write down his blood glucose. We instructed him on when to record it, trying to get at least a fasting reading in the morning, and we asked him to do it after at least 1 meal each day, recognizing he probably wasn't going to do it after all of them. We also started him on a low-dose perindopril and aspirin. And we had planned to bring him back, I think, in a couple of weeks to reassess his various risk factors like diabetes and blood pressure. Now, keep in mind, this was long before COVID in a small center. that where wait lists were less of a problem than they may be today. So I think the idea of delaying him for a little bit at the time didn't seem like a particularly shocking thing to do. Although nowadays, when we think about it, maybe we'd have a different reaction. Hard to know. But when he came back after monitoring his blood glucose and, I think making some modifications to what he was eating, we were satisfied with his results and we allowed him to proceed with his surgery. So why is this important? So surgery does have effects on glucose regulation. The endocrine system does respond to surgical trauma by activating the HPA axis and the sympathetic nervous system. There is increasing circulating concentrations of many endogenous hormones like cortisol, glucagon, growth hormone, epinephrine, and norepinephrine. And the release of these hormones also causes releases of inflammatory cytokines such as TNF-alpha, IL-1, and IL-6. So the body does have quite a response to the stress of a surgery. Oh, there we go. Those are there too. And these changes do result in certain metabolic abnormalities, such as insulin resistance, decreased peripheral glucose utilization, impaired insulin secretion, and increased lipolysis and catabolism of protein in the body. So this is just a little diagram showing what happens, but these processes basically result in an altered state of insulin action, leading to relative state of insulin resistance. And it can actually, so what they say it's really most pronounced early on after operations. Generally, these things can last up to several weeks postoperatively, the sort of hormonal effects after surgical stress. Anesthesia also has an effect on blood glucose. It is associated with hyperglycemia, as well as higher levels of circulating catecholamines, like the ones that we mentioned before. So local or epidural methods have less of a provoking effect on the blood glucose rather than general anesthetic means. When they use volatile agents, it can inhibit insulin secretion and increase hepatic gluconeogenesis. Now, when patients do have higher blood glucose levels in the immediate post-op setting, we know that this can, at least looking at animal models initially, can lead to poor wound healing, immune dysfunction, infections, renal allograft rejection, and increased, well, this part probably wasn't from animals, but increased healthcare resource utilization. But there is probably a balance, and we're going to get to this in a little bit, but hypoglycemia, as one can imagine, is also not ideal, and we can infer that from the NICE sugar study, which we'll talk about shortly, that told us about how intensive glucose control therapy can actually increase mortality. So this next slide here, this is just from Diabetes Canada. This is just looking at different targets for blood glucose while in hospital. So when we talk about normal hospitalized patients who are not undergoing surgery, who are on the ward, so the non-critically ill, we're generally aiming for a preprandial blood glucose of 5 to 8 and any random value less than 10. In the ICU, targets would be 6 to 10. In CABG surgery, 5.5 to 11.1. For other surgeries, 5 to 10. In ACS, 7 to 10. In labor and delivery, we aim for a bit of a lower target from 4 to 7. Now, these are from Diabetes Canada. I think from reading those recommendations, most of them come from retrospective studies, clinical experience, and clinician judgment, not necessarily from RCTs. So let's talk a little bit about NICE sugar, or intensive versus conventional glucose control in critically ill patients, from New England Journal of Medicine. So this was done in 2009, 42 hospitals, mostly academic and tertiary care centers. It was a parallel group RCT looking at medical and surgical ICU patients. These were patients who were expected to be in the ICU for 3 or more days. They were randomly assigned to being either in a conventional control group of 10 or less for blood glucose concentration. These are all millimoles per liter, or intensive control target of 4.5 to 6. And their primary outcome was looking at 90-day mortality. They did have blinded allocation, but the clinical staff were aware once they were treating the patients as to what groups they were in. 90% of these patients or thereabouts were from Australia or New Zealand. And the blood glucose measurements were typically obtained via arterial line when they could. And they tried to discourage the use of capillary glucose monitoring. Insulin was provided via IV, as we often see in ICU patients, and it was analyzed via intention to treat. So I won't go into all the detail for this. But sufficing to say that the assigned treatment was administered in over 99% in both the intensive and the control group, and they lost about 10% of the people in the intensive control group dropping out, and about 7.4 in the conventional group. So overall, not super different between the two. And when we look at the groups here, you can see that the blue line in the top graph is the intensive control, looking at days after randomization and their blood glucose levels. Now they didn't use millimoles per liter. This is because it's from New England Journal, but if you convert from one to the other, this would be the equivalent of the target. And the conventional group is in red. And you can see even in the intensive group, they didn't achieve their intended range, even despite intensive therapy in general. Now, this chart's very hard to read in a PowerPoint, so we're not going to go through all of it, but I'll summarize some of the key points to say that 90 days after randomization, 829 out of the 3,010 patients in the intensive control group had died, so that's 27.5%, compared with 24.9% in the conventional control group, so that's 751 patients out of 3,012. So that is an absolute risk increase of 2.6% for death at 90 days in the intensive control group rather than the conventional control group. The difference, once they also adjusted for some other predefined baseline risk factors, it was still significant with an adjusted odds ratio of 1.14 and a confidence interval that does not cross 1 with a significant p-value. So you can see that certainly just looking at, just over 3,000 patients in each group, and there's quite a notable increase in death in the intensive control subgroup. So when we looked at also the instances of severe hypoglycemia, there was an odds ratio of 14.7 for severe hypoglycemia in the intensive control group rather than the conventional control group. And it wasn't just the number of patients that were affected, but total events as well. So if a patient had multiple events, you can see that the risk was quite high. So let me pull it up here. So the recorded number of episodes of severe hypoglycemia was 272 in the intensive group compared to 16 in the conventional group. So there were a few limitations. Again, the treatment staff were not blinded. It was a bit of an arbitrary decision on inclusion, why they picked 3 days of ICU length of stay. I'm not sure. Maybe if somebody knows, please chime in, but I don't know why they picked that one specifically. The glucose level was above the target even in the intensive group. And again, this is mostly a population in New Zealand and Australia. I say it's hard to know if that truly generalizes to our centers in North America, but I suspect it wouldn't be too far off. So there was a meta-analysis done in 2009 in the CMAJ with just under 14,000 patients, and it did include the study that we just talked about. So they looked at RCTs with adult participants in ICU, and they had a little bit of a different cutoff. So their intensive therapy was defined as having a target blood glucose concentration of 8.3 millimoles or less. And they also looked at 90-day mortality, and they wanted studies looking at mortality as well. They did exclude trials that were just published as abstracts or not fully published, and they had other secondary outcomes that they looked at as well. In addition to their primary outcome of 90-day mortality, they looked at secondary outcomes such as hypoglycemic events of showing, and it's pretty significant, a blood glucose of less than or equal to 2.2. I don't think we need to get too far into this, but this just looks at how they chose to include or exclude studies. There were many that they didn't want because they either weren't randomized, they had the wrong intervention, the patients weren't in ICU, or some of them were pediatrics, so they kicked those ones out. So they ended up with having 26 articles included in their meta-analysis. So here's the forest plot here. And what's interesting when you look at it, so this breaks it up between, if you look at the top third, there's they have studies that were mixed ICU patients, followed by medical ICU patients in the middle third and surgical ICU patients in the bottom third. And the final line here is all ICU patients when they group them all together. And what's interesting is that in the meta-regression analysis, the patients in the surgical ICU benefited from intensive insulin therapy in terms of 90-day mortality, rather than those in the conventional group. But when they looked at the other types, if you can see here, but the medical ICU, the mixed ICU and the medical ICU really didn't have a significant difference. So just to say that we'll just kind of skip ahead from there. So there was also, they noted a six-fold increased risk of severe hypoglycemia noted in the intensive group compared to the control group. Which obviously is not ideal. So there was another meta-analysis done looking at, So lower perioperative blood glucose target levels for reduction of surgical site infections. So this was not one that was looking at mortality specifically, but rather looking at the incidence of infections postoperatively and how that pertains, and sorry, blood sugar and how that pertains to postoperative infections. So they also had an intensive and a conventional group, and they looked at multiple databases over from 1990 to 2015. So if the study was older than me, they threw it out, essentially. The primary outcome, surgical site infection incidence, and they looked at other things like hypoglycemia, stroke, and mortality, but the mortality was not the primary outcome. They found 15 RCTs. They had to be in English. And again, they had to have intensive versus conventional glucose protocols and look at surgical site infections. They did, interestingly, have subgroups in their intensive control group. So they had a very strict group and a group that was less strict. And in general, their targets were a bit more liberal than the nice sugar study in both the intensive and the control groups in terms of what they considered to be those. Again, mostly done in the ICU. They included, interestingly, studies included people who did not have a known history of diabetes, 8 studies that had patients who had diabetes and who did not have diabetes, and then 5 studies with only people who had diabetes. Of the studies, 6 were cardiac, 4 were abdominal surgery, and 5 were other. And I can't recall, but I don't think they mentioned what those others were, but they were not abdominal surgery or major cardiac surgery. And when they looked at, and again, here's another nice little chart that shows you that there were significantly less surgical site infections in both of the intensive group cohorts. So the more strict control and the kind of more moderately strict control compared to the conventional control. There was a higher risk of hypoglycemia, as one could imagine, in the intensive control groups with an odds ratio of 5.55. But it was similar in both the intensive and the moderate, in the very intensive and the moderate intensity cohorts compared to the conventional. So whether you were in the moderate or the high intensity, you did have a significantly higher risk of having a low blood sugar. Interestingly, they did not find a difference in stroke risk or mortality. But just to mention that there was a substantial clinical heterogeneity between the studies in a wide variety of different protocols that were used in them. So I think from looking at this so far, we can infer that maybe there's something unique about the surgical patient specifically with respect to glucose control and how it pertains to outcome rather than maybe medical ICU patients. So is there something different? But what about glucose control before they have their operation rather than just in the immediate perioperative and postoperative period? So what about A1C? So this was a study, and they wanted to see if A1C was a predictor of adverse outcome after a coronary artery bypass. They looked at just over 3,000 patients who had isolated elective primary CABG. And they wanted to see whether A1C was related to in-hospital mortality, renal failure, stroke, MI, a deep surgical site infection or any infection, new atrial fibrillation, and length of stay. And this was done, they were looking at studies, this was done with patients between 2002 and 2006. Pull it up here. So interestingly, if patients they grouped it by A1C less than 7 or 7 and up, I guess was their sort of factor where they determined there was a difference. If you had an A1C of 7 or greater, you had a significantly higher risk of death, renal failure, stroke, surgical infection, other infection, and length of stay. Interestingly, when you look at this, for MI, the p-value didn't quite hit significance. But I sometimes wonder if, had the study size been bigger, if they would have noted a difference, because when you look, there were 4 instances of MI in the group with diabetes, and that was 814 patients total, and 7 in the patients who had an A1C less than 7%. I guess both groups can have diabetes because 6.5 is the cutoff. But yeah, I sometimes wonder if had they had a larger sample size, if it would have also been significant. That I can't answer, but food for thought. Diabetic diet for thought. So yeah, that wasn't that funny. Okay, so perioperative A1C with clinical outcomes, and this is for non-cardiac surgical patients. So this was a retrospective cohort study published in Diabetes Care. And they looked at patients who were admitted for at least a day after non-cardiac surgery. They did not include same-day surgery. So the patient that we would have seen in that preoperative clinic that we talked about would not have been eligible to be in this study. They looked at the National Surgical Quality Improvement Program database to collect data. And they included patients with diabetes, which they said was anyone who was identified as having diabetes on the database, if any doctor wrote they had diabetes, or if it was listed as an ICD-9 code, and they also had to have an A1C within 90 days before surgery. And they had controls that were matched for age, sex, and BMI. They also had 2 controls for every case of diabetes that they included. Oh, I think my thing's frozen. Hold on. There we go. So the primary outcome they looked at was length of stay in a hospital, and they grouped it by 5 different groups. So patients who did not have diabetes. This is kind of interesting when they say diabetes with an A1C less than or equal to 6.5%. So I guess very well controlled. You could even argue maybe they're not diabetic anymore. Diabetes with an A1C between 6.5 and 8, 8 to 10, and greater than 10. I won't dwell on the statistical method because I don't fully understand it myself. I'm not a statistician. So I'm going to skip ahead here. And here's the number of patients you can see at the bottom who ended up in each group. They had 109 in the less than 6.5 group, 202 in the 6.5 to 8, 91 in the 8 to 10. And you can see they only got 47 patients in the A1C of greater than 10%, which I think is kind of pretty representative of patients that we would see. It's not all that common that we see patients with an A1C of 12, although granted, it does happen. When they look at the baseline characteristics in the study, diabetics were less likely to be Caucasian, more likely to smoke, have high blood sugars, be having vascular surgery. And they also had the patients who were kind of in the diabetic group were also had higher hospital length of stay, death in 30 days, and higher risk of contaminated wounds. When they broke it down by each of the groups, not just diabetes versus no diabetes, the length of stay in people with A1C less than 6.5, 8 to 10, and greater than 10 was significantly longer compared to the control subjects. Their p-values are like 0.001 in some cases, sorry, 0.0001. And similarly, one of them is 0.02, but they're all very significant. And interestingly, when they compared that, to the people in the 6.5 to 8% group, so these people for some reason had shorter length of stay rather than even than those with an A1C less than 6.5%. They did a multivariate regression analysis, and they showed that higher A1C was typically associated with increased hospital length of stay after they adjusted for things like age, sex, BMI, the surgery type, and the Charleston comorbidity index, smoking status, and glucose level on the day of surgery. They really couldn't comment on death. They interestingly, there was talk, I think, in this paper about the A1C level being less than 6.5% and why that was increased or why that was associated with an increased length of stay. I think it was postulated that it could be that the increased length of stay was related to greater severity of their underlying illness, as suggested by that group's relatively higher Charleston comorbidity index. So maybe not just the diabetes in those people. Now, what about preoperative A1C and clinical outcomes in patients with diabetes undergoing non-surgical procedures? So, well, this is the same study, but basically the A1C greater than 8 definitely predicted a longer hospital length of stay. Long-term glycemic control was a strong predictor of length of stay, independent of the blood glucose measurements on the day of their actual surgery. But again, small sample size, single site. Some of the control subjects may have had unidentified diabetes. And the study really doesn't talk about, I mean, it wasn't in its aim, so it's hard to criticize it for this, but it didn't talk about whether lowering the A1C actually improved outcomes. So again, that wasn't the focus of that study. So I mean, it's a little hard to criticize it for that. And when we look, so what does JAMA say about perioperative glucose control in patients with diabetes who are having elective surgery? It suggests that in the perioperative period, glucose, this JAMA in particular talks about, and this is contrary to what we just saw, but they talk about how glucose in the immediate perioperative period is more important than A1C, which again is contrary to what that previous study just said. And when we think back about that case that I mentioned at the beginning, other than giving this guy some dietary advice and having him check his sugars and be more conscious of what he was doing, and maybe checking his sugars did influence his eating behavior, that we won't be able to know. We really didn't change his diabetes management all that much. We didn't add another agent. So we really, in a way, didn't follow the guidance, which JAMA points out, which is that if you think you can improve their diabetes control and their A1C is above 8 for an elective surgery, they would recommend delaying. So while we did delay him, we did not actually make his diabetes therapy any better, other than maybe subconsciously influencing what he eats by telling him he has to check his blood sugar. So when we think back about, maybe how I handled that case or how it was dealt with during training, maybe we would do something different today than we did then. So a quick refresher, just a little bit on the management of hyperglycemia and diabetes in the perioperative period. So when patients are going for elective surgery, on the day before the surgery, we tell them to hold their SGLT2 inhibitors. And on the day of the surgery, we tell them to, we don't really give those TZD drugs anymore. But basically, you're going to want to hold everything on the day of surgery. Here it says you can give them their DPP4 inhibitors. I'm just looking at the column most on the right, because most of these patients are NPO on the day of their surgery, generally. It's saying you can take them. I tell patients not to take it. I don't think that I don't feel strongly about it, but I tell them to not take their DPP4 inhibitors. In terms of insulin regimens, we don't need to get too far into this, but just taking note that the kind of insulin that a patient is on will determine how you will titrate it before the surgery because of the length of action of some of these different agents. And this also talks about the non-insulin injectables as well. We won't dwell on this, but just be careful if you're having a patient who's going for surgery and they're on insulin, be sure that you look up what to do with it. Not all insulins are created equal. So I'm just going to skip ahead here. So when looking back at the case that I encountered, again, as a trainee, were we right or were we wrong to delay his OR? I think looking back now, I don't know if I would have delayed it because we didn't really change his diabetes management, but I'm just curious, maybe someone can tell us what their practice would be when talking to patients with poorly controlled diabetes preoperatively. If anyone wants to comment on what they would do differently, or if they had an interesting case, now's a good time. So I will open it up. Does anyone want to say anything? No? I'll give it for another 20 seconds. If there's any case that you guys have encountered that you thought was fascinating from a diabetes management, let me know. No? Not all at once. Okay. All right. So let's talk about a couple quick takeaway points. So just so we can summarize quickly, that poor glucose control before surgery does seem to have an association with increased length of stay and other poor outcomes, particularly in cardiac surgery patients. Poor glucose control immediately after surgery is associated with complications as well, such as poor wound healing and infections. And intensive control therapy may have a role, but particularly notable in the surgical post-op patients rather than the medical post-operative patients. And again, ICU specifically. These are the references. And I just wanted to pause if people had any questions or comments. Okay, it doesn't appear that there's any comments or questions. So I think that's it. Enjoy your lunch. I think it sounds like we'll get out of here a little early. So that's all I have. Any other concerns, burning questions? Essentially, there's a lot of, there's disagree. Oh, I see there's something in the chat. Hold on. Oh, there we go. You are welcome. All right, I'm going to stop the screen sharing and I will conclude.